right. Welcome back. So we'll move on to the second session. The first presentation is titled Insights into the Role of Micronutrients in Inflammatory Bowel Disease by Drs. Golca and Stefanescu. Please.
Esteemed members of the academic community of Grigore de Popa University of Medicine and Pharmacy in Iași, esteemed guests, I am deeply grateful for being today with you in this semi-centennial celebration of George Emil Palade's awarding of the Nobel Prize in the exact George Emil Palade Hall, in which we celebrate this researcher who is so inspiring for all of us. And I am humbled to present our modest research results in the area of inflammatory bowel disease. This research is the result of a multidisciplinary and interinstitutional collaboration, both from the clinical side and preclinical side, and also with the team of Professor Mariana Pintelă from the Petru Poni Institute of Biochemical Sciences. This is the agenda of my presentation, because all this research came from being so curious about the complexity of the mechanisms which lead to nutrient deficiencies in inflammatory bowel disease. How can we get more knowledge on that, and how can we apply it in the clinical practice? Then go through the study which we performed in the gastroenterology department, and finishing with our ongoing work and perspectives of this research. The pathomechanisms in which resides the nutrient deficiencies in inflammatory bowel disease are complex and lean also on inflammation, but also on restrictive diets which patients frequently follow and lead to nutritional deficiencies both on macro and micronutrients. Although anemia is a very common extraintestinal manifestation of inflammatory bowel disease, and iron deficiency anemia have been extensively studied in this area, leading to some input for the clinical practice and also some guideline recommendations, things are totally different with regard to other type of deficiencies, also vitamin deficiencies and other micronutrients such as selenium, magnesium, manganese, copper, or zinc. And this is why we were further challenged to see what can we do more than do serum evaluation of this micronutrients and investigate our patients further from this iron deficiency and iron deficiency anemia. Of course, doing serum evaluation is something very easy, is at hand, it's less costly, but on the other hand, there is a downside of this evaluation because measuring micronutrients in these settings is highly influenced by both inflammation at that certain point, but also it's influenced by a patient's recent diet. That's why studying the literature, we identified that there's another potential method to identify micronutrient deficiencies, which has a more stable concentration and defines better the micronutrient status among patients with inflammatory bowel disease as well. And this was our collaboration with the Petru Poni Institute of Macromolecular Sciences for this cohort of IBD patients. It was a case control study, actually, involving patients with IBD and healthy controls, for whom we evaluated clinical demographic data, parameters regarding inflammation, and last but not least, this hair evaluation of micronutrient status. The healthy controls were recruited among patients who were addressed for a colorectal cancer screening. This is why no other further investigations were performed in this control group. The two groups were not statistically significant regarding age and other social demographic parameters. And as far as the group of IBD patients was concerned, we included both patients with active disease and patients in remissions, about half and half. The results were not surprising, but worrying because we identified statistically significant deficiencies in most of the micronutrients which were evaluated in IBD patients, both in ulcerative colitis patients and Crohn's disease patients, although there were no statistically significant differences in this nutrient status between the two disease subtypes. How can we integrate this findings into the patient clinical picture? We try to see whether there is a correlation between the micronutrient deficiency and disease activity, and this was statistically significant only regarding the calcium level. But considering the complex mechanisms underlying this situation, and not only directly related to intestinal inflammation, we were cautious in interpreting these results. However, it is difficult to see how we can integrate these findings into clinical practice because it's difficult to suspect micronutrient deficiencies in IBD patients since the clinical picture is very poor. So this is clinically undetectable and possibly explain this results of finding no significant correlation between the type of micronutrients and clinical parameters such as BMI. We went further than the gut, and we wanted to see whether these micronutrient deficiencies affect other parameters which highly influence patients' quality of life. And we focused on sleep impairment, given the fact that magnesium deficiency, for example, is related to a significant impairment of sleep quality. We applied the PSQI questionnaire to measure the quality of sleep in these patients and found that among the patients who had deficiency in magnesium, there was also an impaired quality of sleep reflected by two of subcomponents of the PSQI questionnaire, namely the sleep latency and also the sleep duration. We know a little bit less about how we can control this impact of nutrient deficiencies on IBD course, and the current literature is quite scarce in this regard. And this is why our ongoing work is trying to integrate the findings we had in this previous study into developing a linear regression model to establish how can micronutrient deficiencies impact the further disease course. And we developed together with a colleague who is specialist in bioinformatics. I don't have this qualification. And we reached together a model in which, besides the usual parameters involved in evaluating disease activity, namely albumin level, nutritional status, inflammatory parameters, that including this magnesium, iron, and selenium hair concentrations, we can get a better insight into predicting disease activity further. In conclusion, micronutrient deficiencies should also be considered when evaluating IBD patients beyond iron and iron deficiency anemia, although current guidelines are with scarce recommendation in this regard. There is also a potential predictive value of this micronutrient deficiencies for patients with IBD, and there is definitely a need to further research in order to standardize the determinations and establish how we can translate this into the daily clinical practice. Thank you for your attention.
Thank you very much. So it's very interesting. And my question is this something you think you could use for diagnosis, for prognosis, or for intervention? What is the exact translation that you're thinking about?
I think that these deficiencies determined via hair concentrations are quite reliable, so that they can be used both for diagnosis, for follow-up in order after trying to correct them. But I think it will be difficult to implement them into the daily practice because it's quite costly to do this evaluation and it's not readily available in all labs.
I see. And in terms of intervention, if you supplement that, perhaps, I know in cancer, people have done a lot of studies with vitamin D, calcium, vitamin C, and so on. Nothing really showed any kind of effect in colorectal cancer, but I don't know about IBD, if that's, has anybody tried to look at that?
Now there is a team in the US who are trying to do this thing. Actually, the lady researcher who leads this, Stephanie Gold from New York, has contacted me in regard to our research because she was trying to find actually this thing and they were trying to develop this, the research in this direction.
Thank you. Any questions? Yes, Professor Kovic, please.
Can you change the microbiota with these micronutrients? Do you have any data on that or studies?
There is definitely a bidirectional link between this micronutrient deficiency and dysbiosis, and there are emerging studies looking at the vitamin D. These are actually currently available. In 2022, there was a study published in Scientific Reports, if I recall correctly, in which they identified that vitamin D deficiency was linked to a dysbiosis, namely lower richness of species and development of pro-inflammatory microbiota components. So yes, probably there should be more research into this setting, looking further than this vitamin D, which we already have results for.
All right, thank you very much.
Thank you.
We'll move on now to the second presentation. Progress in advanced biomaterials supports for precision regenerative medicine, where we stand, by Dr. Janina Dodi. Please.
Hello, it's a pleasure to be here and an honor also. And I'm going to present today the results that I obtained during a collaboration with the University of Libre de Bruxelles in Belgium. Tissue engineering, the past and the future. So the term firstly appeared when Professor Feng applied for funding to develop a research center dealing with tissue engineering in '85 to the National Committee of Science in California. The proposal was denied, but the professor intended to have this center. Therefore, 2 years later, he resubmitted the proposal with the success. Further, the term tissue engineering was moved forward through the collaboration of 2 doctors, a surgeon and a professor from Massachusetts, Langer and Vacanti, that published the first review in tissue engineering and science in '93. This collaboration is a well-known collaboration through the Vacanti mouse when polymeric biodegradable matrix based on natural polymer, on synthetic polymer, was seeded with cells, bovine cells, chondroitin, was implanted subcutaneously on the back of a mouse. Even though the experiment failed, this led to numerous research in the area of tissue engineering. Nowadays, the tissue engineering is divided, as presented in this figure, in 3 components. One dealing with biomaterials and also synthetic materials that are able to be constructed, for example, in 3-dimensional structure, suitable to grow cells and develop tissues or even organs. The second component is represented by the generation of signals, both physical and chemicals, that needs to be sent from the cells to in order to grow the tissues, the proper tissue that you intend to build. And the third component is composed by the modern technologies such as 3D printing or 3D encapsulation techniques, able to use both components in order to build tissues and even organs. Taking into consideration these components, the first part of my presentation is dedicated to the fabrication and optimizing 3D structure in the shape of a hydrogel scaffold based on biopolymers, namely modified gelatin, hyaluronic acid, also modified, and methyl cellulose. The first step was the modification of materials, since gelatin is well known for the jellification process, but not suitable enough to be 3D printed. Therefore, the gelatin was modified with a methacrylic anhydride, modification that was confirmed by the NMR analysis in the proton spectrum. The methacrylation degree was exactly as presented in the literature, obtained was exactly as presented in the literature, suitable for 3D printing. The same was done with hyaluronic acid. The modification was done since the viscosity of the hyaluronic acid is low, therefore not suitable for 3D printing. And the tyramine groups, phenolic groups, gave this feature. The modification of the hyaluronic acid with the phenolic groups with tyramine substitution of 3.7 was confirmed through the same analysis, NMR spectroscopy in hydrogen spectra. Therefore, the next step was the optimization of the bio-ink based on modified methacrylate gelatin, phenolic compound groups, hyaluronic acid and methylcelluloses by adjusting the concentration of each polymer in order to have a suitable biomaterial ink for 3D printing. We used the experimental design named Box-Becken design in order to have a proper experimental design of this method. The biomaterial ink was printed, extruded through a 3D printing with different nozzles at 37 degrees in dark conditions, in medium cell culture medium, using different enzymatically cross-links. In order to have an optimized biomaterial ink formulation, we used the model of the 3-grid pattern using the 3D printing and the grid printability as a measure. In the preliminary results, we obtained grid printability from 11 to 76. Not enough. Therefore, we moved forward to a mathematically model in order to have a grid printability of 87.3. So we have the biomaterial ink, the bio-ink. It needs to be printed. So the bio-ink was printed pneumatically using different diameter of the nozzles in different pressure and different speeds. And after the printing, the hydrogel was cured using a visible light source at 406 nanometer in order to obtain a stable hydrogel. The ATR, the infrared spectroscopy, confirmed the composition of the hydrogel. The surface of the hydrogel with the best on the best formulation, optimizable formulation, showed a surface with open pores from 20 to 90 micrometers, pores that will increase when the hydrogel will be immersed in cell culture media. This increase in the pores was due to the degradation of the polymers, and we showed that the degradation of the polymers started and was slowly degraded over 3 weeks, losing almost 53% of their initial mass. But this is good. If the polymer is degrading, this means it has the capacity to leave the cells, to gather the cells and to grow on the surface of the hydrogel. The rheological properties of the hydrogels and the mechanical measurements showed that the material, the hydrogel, was elastic, suitable for the intended purpose in tissue engineering, and the cell culture in endothelial cells, using endothelial cells, showed the viability percent higher at 7 days than the control. The control was just hyaluronic acid with no modification. The adhesion of the cells was confirmed on the surface of the hydrogel, was confirmed through the confocal microscopy when marked fluorescent. Oops. What was supposed to be just a normal biocompatibility test, according to the directive of the biocompatibility and the biological activity of the medical devices, was indeed a step to a further research, since after the implantation subcutaneously of the hydrogel, I observed that even if the form and the dimension increased over time from 1 week up to 2 weeks, after 3 weeks, the material integrated perfectly into the cavity, and the vessels proliferated. So it's not just compatible, but also promotes angiogenesis. The animals during the experiment showed no infection or inflammation or other signs since it were measured through the grimace scales and the weight of the animals. So we observed vascularization, neoangiogenesis. Therefore, we performed another test that is in ovo, using an egg, a fertilized egg, in order to observe if the hydrogel, after 48 hours, promotes this formation of the vessels, or comparing with the control. As observed, the surface of the vessels were increased comparing with the control, and also the length of the blood vessels. The results were published in journal in red zone in Q1. Therefore, we had vascularization. Vascularization is a very hot topic in tissue engineering, since most of the vessel structures are using the existing vessels in order to build the tissues, projected tissues. So our question was, can we use the same bio-ink in order to fabricate flexible vessels with small diameters less than 500 micrometers? In the same collaboration, the next step was to build flexible small diameter vascular constructs, but with using different printing technique, coaxial. That the other one was a normal extrusion, but this time we used, instead of the hyaluronic acid that is known for low viscosity, the polyethylene glycol. The same, we modified the polyethylene glycol with tyramine groups in order to have a good printability grid, and phenol content and substitution was confirmed by the same method, NMR spectroscopy. We had, therefore, based on the previous results, again, to optimize the ink formulation, the bio-ink. So we modified the ratios between the polymer concentration of the methacrylate gelatin made from the previous research, the alginate, the methyl cellulose concentration stayed constant since we had previous results. And also we had a different percentage of the concentration for the polyethylene glycol. The parameter for the parameters in the printing were already optimized. Therefore, we adjusted for this type of printing, the coaxial printing. That means a core shell structure using not a dual cross-linking of the hydrogel, but a multi-facet one. This means an ionic cross-linking of the alginate using calcium ions, photo cross-linking with the same light source of the methacrylated gelatin, and also an enzymatic path, a cross-linking path for the polyethylene glycol chains. Same, the printability and the rheology were evaluated, and of the inks, and also for the hydrogels after the printing. And we observed that the elasticity remained the same, but the viscosity decreased. Therefore, since polyethylene glycol is a plastifier used and it's flexible, this means that will help us in order to have blood vessels flexible and not to be ruptured in the due to the arterial pressure. The scaffold were tested for the flexibility, And both the test, the tensile and the compression test, were suitable to be used as support for vascular structures. The compression test force of less than 8 kilopascal was less than the one of the Young module for the small vessels found in the literature. Also, the vessels were folded, and also the core was removed in order to test the elongation, the flexibility of it. This was due to the increased flexibility was due to the polymeric chains of the polyethylene glycol modified with the phenolic groups. The SEM, the scanning electron microscopy in dry states, and also the micro CT and also in dry states, confirmed that we have a hole in the vessel, meaning that was similar to the blood vessels, native blood vessels. But what about in wet state? We perform a micro CT scan in wet state by staining with fluorescent dye the hydrogel. The same structure was confirmed, the structure of a blood vessel. Again, the cell viability test confirmed the biocompatibility of the hydrogel. Also in fluorescence after 24, 48, and 120 120 hours after the incubations with the endothelial cells. This is what we used. But the vessel needs to be able to be perfusible, so flow has to go through it. Therefore, we use the technique in order to, the coaxial printing, in order to form the rounded shape vessel structure, and we remove the interior, the core, the gelatin with the calcium, and then we perfuse we put a liquid to pass through it. Cred că merge. The vessel colored with blue stain passed through the vessel. Whoops. In the second picture, on the burst pressure test, the pressure that caused the rupture of the vessel was higher than the normal pressure, over 200 millibars. This was done with a homemade device in order to perfuse the blood vessel. Since the first study gave us information on the blood vessel formed, on the vascularization of it, we perform again the in ovo test. And the same as previously, we observed numerous blood vessels form, and the surface was higher than the control, and also the length and the diameter of the blood cells. This was done with image J, just analyzed with image J. But it was intended for tissue engineering. So can the cells grow inside and above the blood vessel? Therefore, based on the perfusion test, we inserted cells, endothelial cells, inside the blood vessel and also on the outside, on the surface outside. And you observed through SEM, scanning electron microscopy, and also confocal microscopy, that the cells were highly adherent to the hydrogel membrane, the vessel structure. Again, in vivo assays. So if the first time we observed that we had new blood vessels, let's see what happens in the implantation sites, but not on the subfascia implantation. On the 10 days after the implantation, the gel, we printed something that we could implant it, because that vessel could not be implanted in the subcutaneously. So we printed something similar, the same ink, but in a different shape, in order to have a small, like a cut cross-section of the vessel. We observed that after the second 10 days, slight information, this time confirmed by the determination of the interleukins, was disappeared after 20 and 30 days, but not completely. Also, on 20 days, the blood vessels that were formed near the implantation sites and also on perilesional sites were abundant. But it stopped after 30 days. At 30 days, the blood vessels from the implantation site stopped. So the number of the density remained the same as the 20 days, but in the perilesional site, the blood vessel increased with another 20%. In histology, we observe the same modification, the inflammation from the implantation sites, and also blood vessels formed at the implantation sites, and also perilesionals here marked with green. So we obtain vascular small diameter vessels with key properties as flexibility, structural mimicry, biocompatibility, capacity to perfuse a liquid, and also permeability. The results were published in a journal, the #1 journal in material science from Q1. What's next? Because there are lots of questions that we had during this research. Therefore, what we think, what will happen if we implant, before the implantation of the vessels, we put cells on it, and then visualize with confocal microscopy. This was submitted to a project proposal in this year at the Pathfinder of European Innovation Council. And also we intend to optimize the material and the fabrication method in order to obtain vessels with a uniform distribution of the diameter and also of the form of it. Thank you to my collaborators, international collaborators, and also you for your kind attention.
Thank you. So for the first part, you see this formation of new blood vessels. So
Yes.
What is prompting the angiogenesis and what is mediating? Is inflammation, or there's no cell inside the gel, right? If I understand correctly.
No.
Okay, so you just implant it and then you see the vessels, because that's the major problem in bioengineering. Tissue engineering had always been to have stable vasculature, because you may have this initial response, but then you don't have stabilization of a normal vasculature. So what is prompting this angiogenic response, and how durable is it?
So in the first part, I just observed that the vessels because I have a control. Each time I have a control, I implant a glass sphere in the other part of the back rat. Therefore, I observe on that part all the vessels were lack of them, and then on the other part I observed the vessels that adhere to the materials. They were going inside, like inside of the.
My question is why? Why would that?
Why?
Usually, for example, people put VEGF, some growth factors,
yes.
or migration factors, or
Yes.
for some specific reason. But in your particular case, why do you think
I
it's?
didn't do it. I do. This is the next step will be to put cells in it in order to see if the vascularization that happened is due to the material or just a phenomenon of the natural phenomenon of it. What I think, what was the cause of it was the structure of the materials, the form of the materials that produced this. But why?
Okay.
It's unclear to me since I didn't do further research with the in vivo part. So I think I can do pig in order to have a huge area to dissect properly in order to have a better visualization of it. And also fluorescence. There are a lot of techniques that I can do.
So for the histology, have you looked at, again, I think that the structure of the vessel is very important. So you have to have perivascular cells that will support the endothelial cells. It's not just the endothelial cells. So have you looked in your, whether they recruit pericytes or smooth muscle cells or something to support?
Visualization.
Right. Okay, and the best case scenario that actually this works, what kind of application do you see? Because, you know, each tissue has very different type of vascularization, different vessels, different function. So skin, of course, you can put under the skin and look at that. But do you see something for heart? What kind of tissue engineering are you seeing this?
You show vessels first under the skin. So just put the vessel as it is and connect it with a normal blood vessel to see if it integrates and then see. I didn't think that far.
Okay. All right. That's fair enough. Okay. Any questions?
My question was in the line with the last question, that how can we get money out of your invention? How can we translate this into money for the university?
You also ask about money, and let's first have money to finance the rest of it, and then think how to do money out of it.
I have 1 million in my pocket, but you need to convince me to get the money out.
New vessels, with your heart, with your assisted heart, that will need vessels. It can be for example, could substitute the in vitro or ex vivo heart support. So just apply to your heart this vessel, the fabricated vessels, and connect it in order to see for example, the perfusion of your heart.
Thank you.
But you need the hypothesis. I mean, people have tried this for 30 years with cells, with all kind of, gene therapy,
Yes, I know.
and everything has failed quite, spectacularly. So I think you need some sort of hypothesis. You cannot just, have the material first and then think about it. I think you need to address the problem.
Yes, but first, the first material was intended to be used in bone. That was the intended application.
Right. Well, the ear is just cartilage, so you don't have vessels. You don't have to worry about that.
I didn't think about the vascularization then when we fabricate the material. I just done the biocompatibility assay.
Okay.
And then I noticed that something different is happening. It's just, okay, it's biocompatible, of course. It doesn't have edema, inflammation, nothing. But why are the vessels there? So that's why I was going through a different path then.
All right. Well, thank you very much. Good luck. Okay.
Excuse me?
Yeah.
I have a question, please.
Of course. Yeah, sorry.
Yeah, thank you for your presentation. I have just a question out of curiosity. So, in the context of regeneration of blood vessels, is the regeneration of veins is kind of more challenging than arteries due to the complexity of the vein structures with valves and everything?
Sorry. So, probably I will start with the arteries and then with the veins, but I didn't check this.
Okay, thank you.
Any other question? No. All right. Again, thank you very much. And we'll move on to microbiota and CKD. by a group. Dr. Voroneanu, please.
Hello. For a better understanding of the subject, please allow me to speak in Romanian. Primul interes pentru microbiotă în grupul nostru a apărut în urmă cu câțiva ani, când un pacient vechi a venit cu niște analize extrem de entuziast și ne-a spus că a făcut la un laborator privat o analiză a microbiomului intestinal și ne roagă să interpretăm împreună această analiză. Pe cât de încântat era pacientul, pe atât de speriați eram noi, pentru că experiența pe microbiotă era una extrem de limitată, așa că ne-am dus acasă și am citit și ne-am dat seama că această poveste a microbiotei este una extrem de fascinantă, care se regăsește practic în toate domeniile medicinei și acest lucru se relevă și în numărul mare de articole care au apărut pe acest subiect în ultima perioadă. Când spunem microbiotă intestinală, ne referim practic la totalitatea microorganismelor care colonizează tractul gastrointestinal. Majoritatea lor, ca și diversitate, ca și abundență, sunt la nivelul colonului. Se pare că numărul de microorganisme din colonul nostru este egal cu numărul de celule pe care le avem în organism. Predomină Firmicutes și Bacteroides. În schimbul pensiunii complete oferite de organismul nostru, aceste bacterii, acest virus care sunt în microbiotă, oferă o serie întreagă de avantaje pentru organismul nostru. Cum ar fi, de exemplu, reglarea balanței nutriționale și aceștia au un rol important în sinteza anumitor vitamine, cum ar fi cele din grupul B și K, în degradarea oxalaților din dietă sau în biotransformarea acizilor biliari conjugați. De asemenea, un impact major îl au în degradarea fibrelor din dietă și formarea acizilor grași cu lanț scurt. Acești acizi grași cu lanț scurt, în speță butirat, propionat și acetat, au impact semnificativ atât pe metabolismul lipidic și glucidic, pe inflamație și pe stresul oxidativ. Și dacă vedeți aici, aceștia vor determina creșterea nivelului de peptid Y și GLP-1 la nivel intestinal și vor determina prin aceștia creșterea secreției de insulină și scăderea secreției de glucagon la nivelul pancreatic și captarea glucozei și o creștere a captării de glucoză la nivelul țesutului muscular și țesutului adipos. În ceea ce privește metabolismul lipidic, butiratul va determina creșterea oxidării acizilor grași și o scădere a lipolizei la nivelul țesutului muscular și adipos. Un alt impact important al acizilor grași cu lanț scurt reprezintă menținerea integrității intestinale. Practic, intestinul nostru este format dintr-un singur strat de celule. Acest strat de celule au cili, au mucină și au între ei niște joncțiuni foarte strânse, aceste joncțiuni ne permițând practic să pătrundă antigenii și patogenii în circulația sistemică. Acizii grași cu lanț scurt, butiratul, acționează și protejează și favorizează acest lucru. Ce face? Pe de o parte determină sinteză de mucină, determină sinteză de interleuchină 18 și reglează anumite proteine importante din aceste joncțiuni strânse. Pe de altă parte stimulează limfocitul B să producă imunoglobulina A. Prin aceste mecanisme locale permite practic menținerea integrității barierei menționate anterior. De asemenea, are o serie întreagă de efecte și la distanță, printr-un impact asupra celulei dendritice, stimulând acele molecule care vor determina expresia și formarea de limfocit T cu toleranță imună, cu menținerea toleranței imune, T-reglator și mai puțin limfocit T cu capacitate inflamatorie. De asemenea, inhibă recrutarea neutrofilelor, inhibă activarea macrofagilor și inhibă histon de acetilaza prin aceste mecanisme, stimulând sinteza de interleuchine antiinflamatorii, cum este interleuchina 10, și scăzând sinteza de citochine pro-inflamatorii. În momentul în care în organismul nostru există un stres oxidativ, este sintetizat acest factor care se numește NRF2 și care codează practic o serie de enzime antioxidante. Butiratul are un impact direct asupra sintezei de gene a enzimelor antioxidante și reducerea stresului oxidativ. Ce se întâmplă la pacientul cu boală cronică de rinichi? La pacientul cu boală cronică de rinichi este disbioză și disbioza este prezentă încă din primele stadii ale bolii. După cum puteți vedea în acest experiment foarte elegant, pacienți care au o rată de filtrare glomerulară de 53,7 ml pe minut, deci destul de bine prezervată, dar Dacă vă uitați la diversitatea bacteriană, observați că nu există o diferență majoră, dar dacă vă uitați la speciile bacteriene, observați că cel din populația generală are predominant Ruminococcus și Roseburia, care sunt niște specii bune, producătoare de acizi grași cu lanț scurt, pe când un pacient cu boală cronică de rinichi are în special Bacteroides. Mai mult decât atât, se pare Nu, să dau mai departe. Se pare că fiecare fiecare stadiu al bolii cronice de rinichi are o microbiotă diferită, după cum puteți vedea în acest experiment. Și atât din punct de vedere al speciilor bacteriene, cât și al diversității bacteriene. Practic, cu cât boala cronică de rinichi progresează, cu atât bogăția de specii bacteriene este mai redusă. Practic, putem discuta de peste 76 de specii care diferă semnificativ de la un stadiu al bolii cronice de rinichi la altul și nu am să le menționez pe toate, ci am să vă arăt un lucru foarte important pe care l-au făcut cei ce conduc acest studiu. S-au gândit așa, că de multe ori noi nu diagnosticăm la timp boala cronică de rinichi și că de multe ori pacienții, în loc să-și facă creatinină sau un sumar de urină sau un raport proteine-creatinină urinară, se duc și fac o analiză sofisticată, cum ar fi cea a microbiomului intestinal. Dacă pacientul tot face această analiză sofisticată, am putea găsi o specie bacteriană care să poată fi corelată cu o boală cronică de rinichi într-un stadiu precoce? Și răspunsul este da. Dacă în microbiota unui pacient este Bacteroides egertii, acesta ar putea însemna că pacientul are boală cronică de rinichi într-un stadiu precoce și dacă vă uitați un pic, pare să aibă o capacitate de predicție mai bună decât a toxinelor uremice, mai bună decât a raportului proteină-creatinină urinară și mai bună decât a banalei ureii serici pe care o determinăm tot timpul. Autorii spunând că această specie, Bacteroides, are o performanță superbă în diferențierea controlului de stadiile inițiale ale bolii cronice de rinichi. Ce se întâmplă în stadiile avansate? În stadiile avansate, peste 190 de specii sunt diferite față de control și dacă ne uităm, practic avem specii care au un echipamentul enzimatic urează și uricază și mai puțini specii care pot să producă acizi grași cu lanț scurt. Și s-a încercat să se explice de ce acest lucru, de unde vine această modificare. Și datele sunt din această vară, 72 de pacienți cu boală cronică de rinichi în stadiu precoce și în stadiul avansat și 20 de pacienți control. La acești pacienți s-a făcut metabolomică și genomică și ce a observat? Că una din genele care catalizează care codează această enzimă carbohydrate active enzyme, care ce face? Practic degradează fibrele din dietă, este redusă la pacientul cu boală cronică de rinichi în stadiile avansate. Deci, practic, un pacient cu boală cronică de rinichi în stadiu avansat își pierde capacitatea de a degrada fibrele din dietă. În plus, enzima care codează o serie întreagă de molecule implicate în sinteza de amoniac este în cantitate crescută. Pacientul cu boală cronică de rinichi, practic, având o capacitate redusă de digestie a fibrilor și o capacitate crescută de sinteză de amoniac. Aceasta asociindu-se cu o rezistență crescută la antibiotice și cu o virulență crescută. Nu este de mirare că un pacient cu boală cronică de rinichi are un nivel crescut de toxine uremice și că nivelul de toxine uremice este corelat cu o creștere a mortalității cardiovasculare și a mortalității generale. Spuneam anterior că este foarte importantă bariera intestinală care nu permite pătrunderea antigenilor și a patogenilor în circulația sistemică. Un pacient cu boală cronică de rinichi are această barieră afectată și vedeți în acest studiu foarte elegant pe șoricei cu boală cronică de rinichi indusă prin nefrectomie parțială. Observați că nivelul de Clostridium crește semnificativ la șoarecul cu boală cronică de rinichi, că nivelul de proteine importante în menținerea joncțiunii strânse dintre celule este redus, permeabilitatea intestinală crește foarte mult și numărul de celule apoptotice de la nivelul colonului este crescut. Mai mult decât atât, noi avem în intestin o serie întreagă de macrofage. Aceste macrofage sunt tolerante. Această populație de macrofage este reînnoită permanent din circulație, cele care provin din circulație fiind inițial proinflamatorii și trecând printr-o serie întreagă de etape de transformare. La șoricelul cu boală cronică de rinichi, numărul de macrofage este similar, dar raportul dintre macrofagele proinflamatorii și cele tolerante este crescut în favoarea celor proinflamatorii. Nivelul de citochine proinflamatorii este crescut și vedeți în această imagine o frumoasă celulă mononucleară care practic trece prin peretele endocapilar. Practic, boala cronică de rinichi induce o stare de colită subclinică cu expansiunea citochinelor proinflamatorii. Iar dacă administrăm lactobacil, vedeți că nivelul de citochine proinflamatorii se reduce. Și acest lucru nu se traduce doar la șoricelul experimental, ci și în datele din populația umană. Practic, vedeți o corelație inversă între nivelul bacteriilor producătoare de acizi grași cu lanț scurt, cum ar fi, de exemplu, Roseburia și Fecalibacterium, și inflamație. Acesta se asociază și cu un nivel mai redus al malnutriției protein calorice și cu un risc mai redus de mortalitate la pacientul dializat. Ce se întâmplă la pacientul transplantat? Și pacientul transplantat are disbioză. De ce? Pentru că are stres chirurgical, pentru că trebuie să utilizeze antibiotice, pentru că ia imunosupresoare, pentru că ia inhibitor de pompă de protoni și are o serie întreagă de modificări dietetice. Primul lucru pe care îl remarcăm este o reducere semnificativă a diversității microbiene, după cum puteți observa în acest slide-uri, și o creștere a nivelului de proteobacterii la această categorie de pacienți, proteobacteria fiind asociată cu un status pro-inflamator. Nivelul de bacterii, așa zis, bune, respectiv Ruminococcus sau Fecalibacterium, sunt în cantitate mult mai redusă. Și acesta este un aspect important. De ce? Pentru că s-ar asocia cu o serie întreagă de elemente negative la pacientul transplantat, cum ar fi, de exemplu, creșterea riscului de infecții urinare. Se pare că cu cât avem mai puțin Fecalibacterium și Rombutia, după cum puteți vedea aici, nivelul de enterobacteriacee crește, nivelul de enterobacteriacee din colon este asociat cu riscul de infecție urinară, atât într-o corelație simplă, cât și într-o analiză multivariată. Practic, cu cât avem mai multe bacterii bune, cu atât avem mai puține enterobacteriacee și un risc mai mic de infecții urinare. Disbioza se asociază și cu un risc mai mare de rejet a pacientului cu transplant, iar aceste specii, Fecalibacterium, Coprococcus, Bifidobacterium, sunt asociate cu un risc mai mic de rejet. Pacientul transplantat are un risc mare și de diabet și se pare că o bacterie care îl protejează este Akkermansia. Și dacă vă uitați în acest grafic, vedeți că la pacientul control și cel transplantat care face diabet post-transplant, nivelul de Akkermansia inițial este similar, dar la cel transplantat, în momentul în care face diabet, nivelul de Akkermansia scade semnificativ. Lucrurile se complică și mai mult dacă pacientul are imunosupresie cu tacrolimus. De ce? Pentru că se pare că tacrolimusul determină o scădere a cantității de butirat de la nivel intestinal, cu o scădere a nivelului de GLP-1 și cu o scădere a secreției de insulină. Dacă administrăm butirat la un asemenea pacient, și aici vedeți date de la animalul de experiență, nivelul de butirat crește semnificativ, nivelul de GLP-1 și de peptid Y crește semnificativ și sinteza de insulină crește și ea. Microbiota se asociază și cu calitatea vieții și cel care pare să aibă un impact favorabil este Fecalibacterium brauniții. Și nu în ultimul rând, există o serie întreagă de date și în ceea ce privește microbiota și supraviețuirea pacientului. Datele sunt între diversitatea bacteriană și riscul de deces. Observați cu cât microbiota este mai diversă, cu atât riscul de deces al pacientului transplantat hepatic este mai bun. La pacientul transplantat renal nu s-a semnalat nicio diferență. Și dacă tot ne-am apucat de cercetat și de căutat în literatură, împreună cu colegul nostru, doctorul Nistora, am făcut și o meta-analiză care a fost publicată și am făcut și o serie de date, avem o serie de date originale, 170 de pacienți au fost incluși, dintre acestea s-a reușit o extragere a ADN-ului și o prelucrare la 136 de pacienți. Dintre aceștia 48 erau pacienți cu hemodializă, 75 de pacienți cu transplant renal, 13 erau pacienții control, rezidenții noștri și le mulțumim. S-a observat că cele mai abundente de specii au fost, așa cum vă puteți aștepta, Firmicutes și Bacteroides, Firmicutes cu mop și Bacteroides cu maroniu. și că și în grupul nostru proteobacteria, cea cu verde fosforescent, este în cantitate mai mare la pacientul transplantat și la pacientul dializat, fără ca între cele două să fie o diferență semnificativă statistic. Practic, 7 genuri sunt diferite de la o categorie la alta, de la un lot la alta. Pentru pacientul hemodializat, ne-a mirat faptul că avea Akkermansia în cantitate foarte mare, o bacterie foarte bună, iar pentru pacientul transplantat, Fecalibacterium și Roseburia, care au și ele un impact foarte, foarte bun. În momentul în care am făcut o analiză comparativă, am văzut că la dializat, pe lângă Akkermansia pe care vi l-am menționat, o altă bacterie din grupul Ruminococcus, care este asociată frecvent cu o lezare a intestinului și cu polipoza intestinală, era în cantitate mare, iar la pacientul transplantat, pe lângă Roseburia, aveam și această megasfera, care este iar o bacterie pozitivă, o bacterie bună, care produce acizi grași cu lanț scurt. Surpriza noastră a fost ca grupul control, grupul de rezidenți, să aibă în special Tizerella fiind o bacterie nu favorabilă și care se asociază cu un stil de viață deficitar și cu o nutriție deficitară. Drept urmare, am făcut chestionare alimentare pentru toți pacienții incluși în lotul de studiu, chestionare alimentare care sunt analizate în momentul de față. Vă mulțumesc!
Mulțumim. Din nou, ca intervenție, cum vedeți datele astea ați dat exemplu pacientului care a venit la dumneavoastră cu, spectru de... Cum ați folosit această informație pentru tratament?
Deocamdată nu am folosit această informație în niciun fel, pentru că ideal ar fi să vedem ce îi lipsește pacientului și să-i dăm un medicament care să suplinească deficitul bacterian pe care îl are pacientul respectiv. Dar din datele pe care le-am citit până acum, nu suntem siguri dacă un pro sau un prebiotic pe care îl administrăm noi sau un simbiotic va face într-adevăr un lucru favorabil, pentru că s-ar putea să interacționeze cu celelalte specii bacteriene de la nivelul colonului lui și impactul să nu fie la fel de bun așa cum ne-am fi așteptat. Deci pur și simplu le-am văzut, dar nu am început un tratament intervențional la acești pacienți.
Dar în literatură sunt studii intervenționale, cu transplant de materii fecale sau ceva de genul ăsta?
Da, sunt studii intervenționale cu transplant de materii fecale, sunt, dacă îmi permiteți, și cu simbiotice și probiotice și prebiotice. Datele sunt prin reducerea inflamației. Sunt puține date în ceea ce privește reducerea disfuncției renale și o ameliorare minimă a ratei de filtrare glomerulară, în special reducerea inflamației. Cele cu transplant de materii fecale sunt într-adevăr mai pozitive, dar sunt în special la cei care făceau infecții cu Clostridium recidivante. Întrebări?
Un comentariu să fac, de asemenea, să uităm că una dintre pietrele unghiulare ale tratamentului din transplant este micofenolatul de mofetil, care are impact direct pe microbiotă și pe epiteliul digestiv. Și una din întrebările care, de exemplu, noi ne punem de asemenea este dacă poate fi modulat, apropo de întrebarea foarte corectă, de exemplu, la pacienți cu disbioză importantă, să scoți cu totul cel-septul și să pui pacientul ăla pe, belimumab și alte lucruri. Deci asta ar fi un alt unghi al unei intervenții directe. Deci cumva ca să diferențieze în subgrupe de pacienți în care există niște probleme.
Felicitări pentru cercetarea întreprinsă. Într-adevăr, trebuie să mergem dincolo de amprenta microbiană în diverse patologii, fie ele digestive, extradigestive, pacienți cu imunitate normală, pacienți imunodeprimați. Și de aceea studiile în vigoare, noi realizăm un transplant de microbiotă fecală în cadrul Institutului de Gastroenterologie și Hepatologie. Nu avem studii în derulare pentru alte indicații decât cele care sunt acoperite momentan din motive de siguranță și din cauza faptului că la nivel european acum se modifică legislația de încadrare a transplantului de microbiotă care va intra sub egida transplantului de țesuturi și organe. Nu știm după aceea cum vom mai reuși să cercetăm ceva în acest sens. Dar cred că impactul metabolic al microbiotei și modul în care micromediul imun local răspunde la aducerea unui probiotic sau unei întregi comunități bacteriene la nivel intestinal dictează practic răspunsul unui tratament modulator. Și după cum e excelent anticipat domnul profesor Cobi, ca de obicei, pacienții care suferă, care prezintă medicație cronică imunomodulatoare sau imunosupresoare sunt o categorie absolut particulară care vor necesita intervenții mult mai complexe și intricate, atât din punct de vedere al microbiotic și asupra imunității.
Ok.
Face parte și dintr-una dintre elementele grantului nostru.
Da.
Întrebare, care este zona în care microbiota poate influența, apropo și de ce ați arătat, celule dendritice, bla, 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 la pacienți cu neoplasm și în ce măsură ar merita să studiem treaba asta și dacă aici ar fi o direcție?
În mare măsură, da. Sunt studii deja clinice.
Da.
S-au văzut diferite corelații, mai ales la tumorile hepatice și sunt studii la National Cancer Institute, unde se... Da. Sunt studii în desfășurare, fără discuție.
Deci
Da.
ar merita să avem
Fără
una
discuție.
dintre problemele importante ale
Și sunt și studii clinice și studii pe animale, foarte extinse, mai ales la MD Anderson. Pentru carcinomul hepatocelular sunt studii extinse cu diverse tipuri de microbiotă și intervenții. Foarte interesant, da.
Dacă îmi permiteți și mie.
Da.
Bună idee, foarte interesant studiu, felicitări pentru grant. Cum a început cu un caz clinic care vine cu un... E într-adevăr foarte interesant, pățim și noi așa ceva, numai că aceste teste nu sunt recomandate de către societățile profesionale pentru diagnosticul unor boli. Încă n-am ajuns în acel moment în care să studiem microbiomul și pasul 2, să dăm un tratament vis-a-vis de probiotic, prebiotic, de-aia e foarte pentru așa ceva. Felicitări!
Mulțumim și noi așteptăm o colaborare cu gastroenterologia să ne extindem pe domeniul ăsta al microbiotei, inclusiv al transplantului de materii fecale.
Doamna doctor, cel care are experiență foarte mare în acest lucru.
Vreau să-i mulțumim Georgianei și pentru că ne-a direcționat către echipa de cercetare a microbiotei, echipa domnului Ivanov. A fost ideea Georgianei, cu ea am vorbit și ea ne-a spus cine face, unde face. Și atunci a fost o colaborare foarte bună pornită de la Georgiana.
Pe de o parte, noi ne-am asumat răspunderea, deci fără discuții, și aici o spun limpede, dar gândește-te că transferul de materii fecale la bolnavul cu sindrom diareic sever, eventual și Clostridium transplantat, acolo se justifică o intervenție de genul ăsta și este și etică. Deci cred că am putea să începem la un subgrup lucrul ăsta fără probleme. Iar noi ne asumăm, nu e o problemă. Whatever. Deci, compassionate use, în partea cealaltă, last resource treatment, pentru că, într-adevăr, dacă tu ești imunodeprimat, ai transplant și ai Clostridium, ești într-o zonă foarte pe marginea prăpastiei și așa mai departe. Deci, cred că nu e o problemă. Și, sigur, cu acordul pacientului, fără discuție.
Mulțumesc. Okay. So again, we have a slight change, and last but not least, we're going to hear the presentation, the cannabinoids and pain, the good, the bad, and the ugly by Dr. Tamba, please.
Hello, thank you for inviting me here. Presentation. Coming. It's going to be a okay. Can I stand here? I still need to see my presentation. So the presentation that I'm gonna have today is about medical cannabis. It's a topic that I think it's becoming more and more public in Romania, at least. And after so many years, it's good to have live and kicking democracy. So I think it's very good that we have an honest scientific discussion about the potential benefits of medical cannabis. However, there's always the good, the bad, and the ugly. I'm a moviegoer, so I always reference movies that I love. The research that I'm going to present is performed in CEMEX. For those of you who've not heard of it, it's a lab that's been founded roughly 50 years ago by Professor Mongiu, initially a pharmacology enzymology lab, went through various stages of development, completely refurbished in 2014 and relaunched in 2016. It's the main preclinical research facility of our university. Which is, of course, an open invitation for those of you who want to do some research projects. A short history about medical cannabis. It's been known and used for thousands of years with various debatable benefits. The Chinese used it, the Greeks, the Indians, and it's also been referenced, of course, in various books written and presented. The typical uses were pain, inflammation, or psychoactive effects. The modes of use traditionally was used smoking. This is the typical use. However, with the rise of medical use of this plant, other ways of administration have occurred. And so you can use teas, you can use vapes, you can use inhalation, you can use even pills with extracts. This is also a chart which presents the tremendous evolution that medical cannabis has had in the last 20 years. And this is led by the creation of specific genetic strains. So normally the plant, the wild plant, would have a THC content of around 2, 4%, 6%. With the advancement in selecting and then, of course, gene manipulation. So the production of new strains led to very high and potent THC strains, which, according to the DA data, can lead to over 16%. But literature data, scientific results also show strains of up to 40% and 50% THC. The landscape, the typical landscape as it is now, is extremely variable. There are countries where you can literally get hanged for owning or using medical cannabis, and then there's, to the other extreme, countries where it's also legal to use it for medical and recreational purposes. This is a map, and you can always see it updated on Wikipedia. There is, however, a difference that I want to point between decriminalization and legalization. So the first one is, if you get caught, you don't go to prison. And the liberalization means there is a legal framework of using it for potential benefits or for recreational purposes. The main bottleneck today is, of course, the United Nations and WHO. It's still classified as a not useful drug. So according to WHO, you cannot trade it. So this means that even, for example, for the United States, if you grow it or use it in California, you cannot cross the border to Nevada. You need to grow and use it in Nevada, and so on. It's a federal indicted drug. We already see the potential downside, the bad of using medical cannabis, and you see that the use in people 12 years old or age old or older has increased a lot in the past 5 years. The first data comes in about the marijuana use disorder. It's like a sort of alcohol abuse disorder. So we see, especially in the younger population, the risks of using it without a legal framework and without the scientific data to back it up. Keep in mind that the push for medical cannabis is mostly justified in North America because of the existing opioid crisis. For those of you who do not remember, roughly 20 years ago, fentanyl was hailed as the holy grail of pain therapy. So we have fentanyl. It's a very potent, a very strong opioid. Pain has been cured, not just treated. 20 years later, the US has a pandemic of opioid overabuse and drug overdose, and especially the blame falls on fentanyl. There is even discussions at the FDA to completely ban fentanyl use, even for medical purposes. So, of course, the push and the challenge for scientific communities to come up with better, safer analgesics. There is also, of course, a lot of tools available for psychiatrists to diagnose the cannabis use disorder, and you have this kind of decision trees, so you can differentiate about the people, you know, who use it for legitimate purposes or good reasons, and people who do not. There are also DSM-5 classified, the cannabis use disorder, which brings me to one of the things that disappoint me still today. We do not have dedicated addiction centers in Romania. You know, they have a small outpatient facility in the psychiatry hospital. The drug abuse, the toxic abuse is not, we don't have specialized clinics for it. Maybe it's an open field. Maybe some of you will want to specialize in that career. And of course, we don't talk only about natural cannabinoids. We also talk about the synthetic ones. Synthetic ones, of course, like always in pharmacology, you start with a natural compound and you derive it, you do some changes to the chemical structure and you create new compounds. The problem we have is the synthetics, of course, are easier to understand by the professional medical community and especially by the pharma community, because we love single molecules, single acting molecules. This is what modern medicine is based upon. However, the downside is the inventive Mexican or Chinese or whatever chemics, scientists, I would not call them scientists, let's say chemical engineers, come up with new synthetic cannabinoids every month. The speed with which the authorities can react is extremely slow. WHO has not updated the list for years now. So every month there are new cannabinoids, synthetic ones reported in various settings, in clinical settings around the world. They are not even forbidden. We, for example, at CEMEX, we import some of these compounds from chemical companies. The official answer when we ask for the import license, for a narcotic import license, is it's not on our list. You can just ship it with DHL. So again, there is a big gap between what regulators can do and what let's say the underworld or the gray world is doing. Coming back to the natural cannabinoids, this is something that I think is extremely important. And now we talk a lot about going back to nature. When we see the importance of the microbiota, for example, not use single molecules, but use various ways to interfere with the organism. There is a so-called entourage effect. And this has been confirmed talking with my colleagues and my friends from the pharmacy school. They said, you know, you always start with the plant, and we isolate and extract, and we isolate and extract. And at the end, we have a single molecule. And when we test it again, there is no more effect. We've lost the effect. So you start with the chamomilla tea, you have some effects. When you end up with a single molecule, a single compound, that effect is gone. Well, the same happens in many cases when we test single molecule cannabinoids, because we lose this entourage effect, which is comprised of many more molecules. Keep in mind, the plant has over 500 known chemicals, and that doesn't mean we quantify them all. And it's extremely difficult to identify all the chemical compounds in the plant. And of course, the bad, if you want to think of it this way, is there are many variants of the plant. Like I mentioned, there's thousands of strains. Think about tomatoes. There's so many types of tomatoes that you know, with different shapes, tastes, colors, and so on. Well, the same is with the cannabis plant. And so basically, we do not know, when it's reported in the literature, we do not know what the patient took, what the concentration of the chemicals in that plant was. So there is a very high degree of variability, which comes from the inherent biological traits of a natural plant. one way to supersede or to overcome this hurdle is the GMP. Well, GMP is a standard used in the fabrication of or the production of pharmaceutical products. It's what Antibiotice uses, for example, or any certified manufacturer. Well, there is what is called a GMP certificate or a GMP standard of production for plants, for cannabis plants. This means that they use clones. So every single plant in a batch is identical genetically to the other one. They use standardized means of growing. So give or take, the plant will have plus or minus 5 to 10% in variability in THC level for that matter. But you would not get 2 different clones or 2 different plants into the same batch. So this standardizes the product. And of course, there is always the challenge of the production chain being, let's say, hijacked. So the major components that you have heard of course, is THC, which is the most famous and the most psychoactive compound. But also have the CBD, the cannabidiol, which is legal in Romania currently. So you don't need any prescription. So there is a lot of CBD-based products. And then there is, of course, the THCA, the acid of the THC, the cannabivarine, the THCV, cannabidiol or cannabinol. So the most major compounds. Now, what we set up to do. And of course, we started with the map where the cannabinoid receptors are located, and we have CB1 and CB2. We're still pharmacologists and want to know how they act, and we've seen them all over the body, including the central brain system. THC, as I mentioned, is psychoactive, but there is multiple articles in literature. Example, reduces the pro-inflammatory state, reduces the atherosclerotic plaques, improves mitochondrial function, has some neuroprotective effect. However, the results most of the times when you try to compare it are all over the place. And I think that what we believe in the lab and in our team is the lack of standardization between the various tests or trials that are reported. The cannabidiol, and we prefer to look sometimes at animal models because they are more standardized. And we've seen that it's used in the model of depression with good effects, in the model of autism, in Alzheimer's disease. So we still have this, let's say, preclinical data, which we believe in, or let's say have more confidence in. And we still have the unconfirmed or let's say folklore type of clinical data. The cannabinol, and you see the difference between the non-psychoactive compounds and the psychoactive compounds. Cannabinidgerol, which is referred to usually as the mother of all cannabinoids, because this is the initial molecule chemically where all the others are derived of. And the way we started this research is around 5 years ago, and we tried to get a grasp on understanding of where we're at. And we looked at the preclinical research of synthetic cannabinoids for pain therapy. One of the main interests in research in CEMEX is pain. But then we wanted to do more, and we got the grasp of where we're at. We selected a couple of compounds, and we started doing in vitro testing. We wanted to see if it's toxic or not. This is the first most important question that stops the clinicians when using medical cannabis, either it's natural or synthetic. It's because, is it safe? And this is the first question we wanted to answer. So we published some papers about the potential neuroprotective effects, an in vitro study on neural outgrowth. And basically, we tested various combinations, various drugs, various natural or synthetic cannabinoids. And the result was, for example, that it's non-toxic. One of them, and extremely important, the LD50, that's lethal dose 50, for the natural product is over 5,000 milligrams per kilogram body weight. This means that the plant we tested, the patient would need to eat around 50 grams, which is enormous in terms of trying to chew buds, flower buds. And even if you eat that much, that doesn't mean that you will automatically die. We estimate you have a 50% chance of dying. There has been no reported deaths from overdose of medical cannabis in literature. For various cases that have been reported, there are other compounds identified in the toxicology report. So people mixed up fentanyl and cannabinoids and, I don't know, maybe it's diazepines and so on. Then we did the acute toxicity testing, and we looked at behavioral data and toxic data for these compounds. And of course, we focused on a GMP plant because we wanted to standardize the quality of the product. One of the the backside but funny story is the main PhD student working on this, and all the research I'm presenting was done by PhD students from this university. So again, it's an open invitation. After 2 months of looking at the data, the young pharmacist comes in and she says, listen, we have an error, we have a problem. I do not find in the plasma levels, I do not find the THC. But I look at the label and it says 16% THC. I don't find it in the plasma. So the plasma level for the THC, I don't know if it's shown. Yeah, it's here. So not detected. And said there is a mistake. And then we looked at the data, but we saw that we have the THCA, which is the acid form. And then we went back to the certificate of analysis for the product. And then we looked at the German pharmacopoeia. And basically, the label, when it says 16%, it's 16% THC plus THCA, because that's the chromatographic measure that they're using. So, and this was the good part, the good surprise, if you want to call it that way, because the THCA, as you see, has a much smaller affinity for CB1 and CB2, but seems to lack the psychotropic effects of THC. At the same time, has better, let's say, potential or possibility of being efficient in pain or inflammation. And then we looked at GWH182, so a lot of the chemical compounds have this number and letters combinations. And this was quite effective in inducing or protecting, let's say, neurons in neuropathic pain model against chemotherapy, because one of the goals is to see, can we use these products in a safe and controlled environment in the clinics? And neuropathic pain is one of the challenges or possibilities that we have. We looked at the data. For example, this is in vitro cultures done by Ioana. I don't know if you had presentation today, but she's also one of my students. She's an oncology in training department. And what we saw is, for example, if we look at the compounds, the GWH and the natural compound in a small concentration, this is at 72 hours. We could still see the neurons. The paclitaxel ones, at 48 hours, the neurons were all dead. So basically, we have proven that adding cannabinoids, some of them, to neuroculture will increase the neuroprotection against the bad effects of chemotherapy. Now, where we're at, if you look worldwide, and actually for medical purposes, there is very limited approvals from the regulatory agency. You have the dronabinol, which is a synthetic THC as a roller or capsule, and it's approved as for chemo-induced nausea and vomiting or appetite booster. You have nabilon, nabiximol, which most of you, or Epidiolex, most of you have known. So Epidiolex is the commercial name. Sativex is for nabiximol, approved for spasticity caused in multiple sclerosis in some countries, or for epilepsy, but this is a plant-derived CBD. Keep in mind that the traditional development in pharma industry takes a lot of time, and I will get to that. We also worked on the trust. And we carefully chose the word trust. Should oncologists trust cannabis? Because at this point, we believe it's a matter of you believe or not in medical cannabis, because there is not enough sufficient scientific evidence. And the next question we asked ourselves, and this is part of the project that Ioana will detail, we started to do with, in cooperation, of course, with Peter Hegge in Semmelweis, a meta-analysis, and try to answer, what about the observational studies? And the conclusion, I will not go too much into it, but for cancer pain, let's say the results are inconclusive, if you want to put it this way. And the main culprit is the lack of standardization in the observational studies. We just asked the patients, what did you take? I smoke a plant. Where did you buy it from? The local shop, the local dealer, or so ever. We don't control the compound that we administer to the patient. We do not control, for example, the quantity. We don't know the percentage of the strain of the THC, the CBD, and so on. So the results, yeah, if we look at the meta-analysis, and this will it's still unpublished data, we're working on the manuscript. The good is that we have some clinical relevant analgesia, even with this lack of standardization of the products administered. The CBD pain decreases the pain with 1.28, but keep in mind that's on a scale from 1 to 10. So a 10-15% decrease in chronic pain of the patient perception, that's significant and is clinically relevant in medical purposes, especially for cancer pain patients. The THC treatment seems to be the best with a 1.47 on a 1 to 10 scale. The RCT, we looked and this was a randomized clinical trial. We aim for that. Of course, there are very few available currently. It's a double-blind randomized clinical trial. The patients had a median improvement in the nabiximol group. But again, one of the bad sides was that there was a short exposure to the drug, only 14 days. Chronic pain takes a lot of time to develop and install, so you can't just cure it or treat it in 14 days treatment. So again, we have a high level of evidence in the RCT, but to the data that we looked upon, there is no clinical relevant analgesia based on RCT. So as opposed to the observational studies that are published. Of course, when we look at pain, placebo is very important. And remember the word I trust in using medical cannabis for my products. The same goes for the patients. Do they trust? Do they believe that the product works in them or not? And unfortunately, there is no way for us to eliminate the bias of placebo when we test for drugs. We always compare against placebo. But for that matter, you know, FYI, ibuprofen or aspirin or salicylic acid has many times failed in clinical trials versus placebo. Okay, so there is a study saying that over 50% of the analgesics we use today have failed at a certain point in time or in a certain trial have failed versus placebo. So this also is a hurdle when we try to actually see if if the plant is or the cannabinoids are actually good in pain or not. The hope, for example, one of the hopes of using medical cannabis is that it will lead to a decrease in the opioids consumption. If we associate cannabinoids and opioids, then we will use less opioids. This seems to be the case. Based on the data published in states that have introduced medical cannabis, the consumption of opioids for medical purposes has decreased. And this is also relevant or demonstrated in some of the papers we looked at. There is a 6 milligram per day decrease in opioid intake while preserving the same type of analgesia for those patients. The cognitive function, this is one of the other fears that doctors have. What about the cognition levels? Well, this is again very diverse because the products with a low CBD content but high THC have a higher risk of acute memory impairment. The products with a high CBD content have a low risk. So this means that it also depends on the type of product that you administer. The effects of cognition depends on, of course, on the cumulative dose, depends on the frequency of use, and it adds a higher risk for younger ages. So yeah, disclaimer, you should not use it before 18 years old, except for, very, very specific cases. There is a very strong relationship between cannabis use and psychiatric disorders. I mentioned at the beginning. The earlier onset of psychosis in some people is also published in the literature, which adds to the fear of trying to use these products. There is evidence linking to other mental illnesses or self-harm, including suicidal thoughts and behaviors. But again, the amount of drug, the frequency of use, the THC potency, the type of product used, and of course, what other medication is the patient taking? This also influences the outcome. So we're most of the times talking about people who use multiple drugs for various pathologies. And this, of course, influences the reports that we see in the literature. Depression and anxiety, we know that the endocannabinoid system is involved in mood regulation and high levels of CB receptors. So there is a hope that we can increase, and there is evidence published already that we can increase the mood and we treat anxiety and depression of the patients by using various formulations of cannabinoids. So yeah, these are the good studies. I hope the presentation will be made available at the end. There's also the bad, because there's sometimes the route was intravenous, for example, and then we show smaller increases or a lack of actual result in treating anxiety and depression. There is also a longitudinal a meta-analysis published on this, and the only conclusion is that we need further studies. Again, another paper with inhaled cannabis flower for the treatment, which shows a positive effect. We can understand why, and we hope that we can understand why it happens like this. More papers. The risk of acute psychosis, there is a paper published in the US, but with patients in Sweden. It shows that the risk is there and it should be taken into consideration. Schizophrenia, adolescents or younger people who use it have a 2-4 times more likely to be diagnosed with schizophrenia when using medical cannabis than those who have not. Alzheimer's disease, and this is where we had some good promising results under publication currently at CEMEX. So we do hope that the neuroprotective effect of the cannabinoids, this is the PET MRI we did, and we saw basically a reduction in the number of size of A-beta plaque deposits on some of the compounds that we tested. This is the immunohistochemistry performed on that. Some more papers still under review, and there is more data from the animal world. But the question and the challenge is always, don't blame the animals. The translation to actual results most of the times fails. So the fact that we're very good in animal study doesn't mean that we can actually translate it to the clinical world. And some more data about the challenge of translation. I'm going to skip on that since my time is off. And this is my last idea. The congenital insensitivity to pain, it's a genetic disorder. The patient cannot feel pain, period. When we discovered it, we thought it's the holy grail. Now we know, now we can treat it. 15 years later, there's still no, or 17 years later, there is still no good use of that knowledge and information that we got from the very few cases diagnosed worldwide. And then I will skip to the last slide. Depression, you can treat it, of course, placebo-like with various ways, the CEMEX lab, and that's about it. Thank you so much.
Thank you. So you mentioned that there might be some anti-cancer effects.
Mm-hmm.
So in the observational studies, have you looked at that? I mean, I understand you looked at the pain, but has anybody looked whether those patients experienced longer progression-free survival or survival?
The data from the clinical trials is still not relevant. I may be wrong. I don't actually they measure the cancer. I'm looking at Ioana because she worked extensively on it. What we do now in the lab is actually we are trying to do that. We have animal models, longer period of cancer generation. So the animal models we use normally, it was a 2 weeks progression rate, and you can't differentiate. The animal will die from tumor inducing to tumor to death 2 weeks. Now we are doing 6 months model. So a slow progressing tumor, either we slow it via the amount of cancer cells we inject or via chemotherapy, and then we add cannabinoids. And I think we did roughly a week ago, we looked at the progression rate. We did the PET MRI studies. It seems to slow the progression rate. But I'm not going to say more. We still need to validate it. There is a question mark if it slows the progression rate, but we cannot say for sure. And it's highly dependent on the product as well.
Any question? Yes, please.
For preclinical models, and it's a project under construction, but soon we will publish the data, and it's very interesting.
That's great. Sounds great. Any other question or comment about the use of cannabinoids? All right. Well, I want
Thank
to
you, yeah.
congratulate all the speakers and thank them for their presentation. And I think we have a break.
We now have a coffee break. We'll work on that. Don't tell anybody for actually 15 minutes. Yeah, and we'll be actually make it 10, please. So we stand in time, and then we'll be back for the last session.